Hi guys, in this video module, let us address eosinophilic lung disorders. Now what do I mean by eosinophilic lung disorders? These are a set of heterogeneous disorders characterized by two important features that binds all these disorders together under the heading of eosinophilic lung disorders. What are those two features? Number one feature is presence of pulmonary infiltrates. So all these conditions are characterized by pulmonary infiltrates on chest imaging. Pulmonary infiltrates. And the second feature is increased eosinophils, increased or more than normal number of eosinophils in either lungs, which we get to know by tissue biopsy, or in the sputum, or on the bronchoalveolar lavage fluid. Okay, so one of these three locations shows elevated eosinophils and there are pulmonary infiltrates present. Such a disorder will be called as eosinophilic lung disorder. Now, these disorders may or may not be associated with peripheral blood eosinophilia. So, there are some subsets of eosinophilic lung diseases where there is no peripheral blood eosinophilia, but majority of the patients, yes, they do have peripheral blood eosinophilia. Okay, now how do we classify the eosinophilic lung disorders or pulmonary infiltrates with eosinophilia? This is a terminology that Harrison gives and most of the respiratory authorities follow. Pulmonary infiltrates with eosinophilia. Harrison categorizes these disorders into 5 groups. Okay, first and the foremost important group is where you have primary pulmonary eosinophilic syndromes. Primary pulmonary eosinophilic syndrome. So under this, we have 3 or 4 important conditions. The first one is acute eosinophilic pneumonia. I will be addressing this in this video module. The second one is chronic eosinophilic pneumonia. I'll be addressing this too. Then we have eosinophilic granulomatosis with polyangiitis, or what we used to call as Churg-Strauss syndrome. Now this I will be discussing in the vasculitis model. For now, just be aware about the condition. And the last one is hypereosinophilic syndrome. I'll be only touching briefly about hypereosinophilic syndrome because a more detailed discussion will be done by my colleague under hematology. Okay, so these are primary pulmonary eosinophilic syndromes. Then we have pulmonary diseases of known cause where eosinophilia is also known to occur. Okay, so the first example I can quote is bronchial asthma. Okay, then the second example we can quote is allergic bronchopulmonary aspergillosis, for which I have made a separate video, right? Okay, then it can be drug-induced conditions where there is pulmonary eosinophilia occurring. And when we talk about drug-induced, I want you to remember most commonly associated drugs which are known to cause pulmonary infiltrates and the pulmonary eosinophilia are NSAIDs and antibiotics. Okay, then comes the question of infections, and infections in itself is an important MCQ zone. Various infections can be associated with pulmonary infiltrates and pulmonary eosinophilia. So this is a table from Harrison that lists all the infections which are associated with the pulmonary infiltrates and eosinophilia. Number one, Loeffler syndrome. As you know, it is most commonly because of the ascaris. It can also be because of the ankylostoma duodenale or hookworm and schistosomiasis. Sometimes when you have a heavy burden of strongyloidiasis, you can have the pulmonary infiltrates and eosinophilia. Sometimes it can also be because of the direct penetration of the parasites into the pulmonary parenchyma. Examples are paragonimiasis, and then you have visceral larva migrans. Then sometimes it can be the immunological response to the presence of organisms in the lung, now which we popularly recognize as tropical pulmonary eosinophilia or TPE, eosinophilia. Okay, now we need to know a few more points about tropical pulmonary eosinophilia, which is usually due to presence of microfilaria in the lung parenchyma, right? It is an allergic reaction to presence of microfilaria and it is type 1 hypersensitivity reaction. Type 1 hypersensitivity reaction, and these patients generally present with bilateral pulmonary infiltrates, and these infiltrates we have to understand that they can be in the form of reticular shadows, but sometimes it can resemble, there will be mottling which might confuse or which might make us think of the differential diagnosis of miliary tuberculosis, because the mottling will be very similar to miliary tuberculosis. And there are other features also which make us suspect miliary tuberculosis in these patients, because these patients often have night sweats, fever, okay, they can have cough, dyspnea. And when we examine these patients, right, these patients can have bilateral crepitations and rhonchi. They might have organomegaly in the form of splenomegaly. They can have hepatomegaly and lymphadenopathy. Hepatomegaly and lymph node enlargement. So all of this sometimes can confuse us to think of the possibility of tuberculosis, right? And we should be aware at least the regions where it is endemic. We should consider a differential diagnosis of tropical pulmonary eosinophilia in patients who present with subacute to chronic illness characterized by cough, dyspnea, and fever, night sweats. Okay, and when you do a chest X-ray, these patients have reticular shadows or bilateral mottling appearance, especially if the patient is coming from the coastal belt, like the Kerala, Maharashtra coastal zone, or the Karnataka coastal zone, or Goa, or on the side West Bengal. So if it's coming from the coastal belt, and if these features are there, we should suspect the possibility of tropical pulmonary eosinophilia. Okay. And if you diagnose it as tropical pulmonary eosinophilia, how do you treat these patients? We have to remember that the drug of choice is diethyl carbazine. The dose is 6 milligrams per kg in 3 divided doses for a duration of 21 days. Okay, so this is how we treat these patients. Okay. Apart from that, certain cystic diseases like echinococcus or neurocysticercosis can be associated with pulmonary infiltrates as well as the eosinophilia, and some non-parasitic infections like coccidioidomycosis, basidiobulomycosis, right, or even tuberculosis. These can be associated with pulmonary eosinophilia and infiltrate. So these are infectious causes. Important things you need to remember is Loeffler syndrome and tropical pulmonary eosinophilia. Okay. Now, coming back to the classification, there are lung disorders which are associated with eosinophilia. Examples are interstitial lung disease, especially idiopathic pulmonary fibrosis, is often associated with the peripheral as well as the pulmonary eosinophilia. Okay. Then we also have hypersensitivity pneumonitis, where you can have bilateral lung infiltrates as well as eosinophilia. Then cryptogenic organizing pneumonia, another condition where you can have lung infiltrates as well as the eosinophilia of the lung. Then we have systemic diseases where lungs are involved in the form of infiltrates and eosinophilia occurs, right? Examples we can quote is radiation pneumonitis. Radiation pneumonitis. Okay, so after the exposure to radiation, you might develop pneumonitis. That's one example I can quote. The other example I can quote is sarcoidosis. Sarcoidosis, you have bilateral lung infiltrates and then you also have lung eosinophilia. Okay, then third condition we can think of is Sjogren's syndrome. So in Sjogren's also sometimes there can be lung involvement, and when there is lung involvement, you might have eosinophilia. Okay. Then there are malignancies which can be associated with eosinophilia, that can be localized lung cancers like the adenocarcinoma of the lung, or it could be secondaries, or systemic malignancies like leukemia and lymphomas, right? So this is how we classify pulmonary infiltrates with eosinophilia. Okay, now let us talk about the primary conditions. First, start with acute eosinophilic pneumonia. Okay, now what is this acute eosinophilic pneumonia? Basic thing we already know, right? These are the patients where there will be pulmonary infiltrates and there should be evidence of increased eosinophil either on tissue biopsy of the lung or in the bowel fluid or in the sputum. So that characteristics will be seen in these patients also. And as the name says, acute eosinophilic pneumonia, these patients are going to present with an acute illness, right? So these patients present with acute illness which is very similar to or resembling ARDS. So very often patients with acute eosinophilic pneumonia are mistaken for ARDS, and they are usually being treated as cases of ARDS only when these patients are subjected to bronchoalveolar lavage and the bowel fluid shows very elevated levels of eosinophils. That is when we start thinking of acute eosinophilic pneumonia. But when you look back at the patient's history, you might hold potential clues to think of this could have been a case of acute eosinophilic pneumonia rather than ARDS. So what are those clues? Okay, when you look at the patient presenting with an acute respiratory distress syndrome like a presentation, and if the patient's Age is in the range of 20 to 40 years. Gender is mostly male, and he has important risk factors in the form of smoking. Especially, he has recently started smoking, recent smoker, or he has recently switched to electronic cigarettes or e-cigarettes. E-cigarettes. Such a patient, when they present with complaints of cough, fever, night sweats, and dyspnea. Dyspnea often moderate to severe in intensity. And obviously all of this in acute presentation. So the duration of symptoms by the time they present is less than 1 month. Most patients, the symptoms peak within 1 week. So because symptoms peak within 1 week, majority of these patients present to hospital within 1 week of the onset of symptoms. And such a patient, when we investigate on the chest X-ray, we will see bilateral infiltrates on the chest X-ray. Okay, and these infiltrates on the HRCT might look like ground glass opacities. Okay, these patients with this clinical presentation with severe dyspnea, bilateral infiltrates on the chest X-ray, and when you do an ABG, these patients would probably show severe hypoxia or type 1 respiratory failure. Now we have all the sufficient data to call this patient as having ARDS. Right? There are bilateral infiltrates on the chest X-ray, and when I did a ABG, there is type 1 respiratory failure. PaO2 by FiO2 ratio criteria for Berlin might meet. So I would end up calling this case as the case of ARDS. So most of these patients are either mistaken for an acute infectious pneumonia or ARDS, and they are being mostly managed in the ICU because they are generally severely ill at the time of presentation. Okay, but when they are not responsive to standard ARDS care, or when they are not responding to the antibiotics, you start thinking of other possible causes. That is where you probably do a bronchoalveolar lavage, and the BAL generally shows that there is more than 25% of eosinophils in the BAL fluid. Okay, so this is a potential clue in your exam. Whenever they mention that the BAL was done, a patient presented with clinical picture resembling ARDS, BAL was done, more than 25% eosinophils present, it is suggestive of acute eosinophilic pneumonia. Obviously, the duration is important. The presentation is in the form of less than 1 month of duration of symptoms. Okay. Now, the next question is, when we do his CBC, do I see peripheral eosinophilia in these patients? The answer is mostly no. So there is no peripheral blood eosinophilia at the time of presentation. There is no peripheral blood eosinophilia at presentation. Okay, but between first to third week, these patients might develop eosinophilia. So eosinophil count can start going up peripherally in the first to third week with a mean eosinophil count of around 1.7 K per cubic millimeter. Okay, so it's that at the time of presentation, as I've already told you, right, majority of the patient present within 1 week of the onset of symptoms. So when they present to us, if you do the CBC, their peripheral eosinophil count will be normal. So you can simply relate to the condition like this. So probably patient started smoking recently. We don't know the pathophysiology, but we can assume that the substances in the smoke triggered an allergic response in the lung, and there was intense eosinophilic inflammation produced. Now the eosinophils, which are now primarily present in the lung, will start spilling over to systemic circulation later. That's how you can remember it. So it starts with the lungs, then eosinophils appear in the peripheral circulation. Okay, now we have a clear idea, right? So mostly we will be able to diagnose these patients only if you have a very high index of suspicion, especially young individuals, young males, recently starting the smoking or recently introduced to e-cigarettes, presenting with acute respiratory illness, very much resembling the pneumonia at clinical presentation, and on evaluation almost looking like the ARDS. Suspect possibility of the acute eosinophilic pneumonia also, and do a BAL. And if BAL shows that there are more than 25% eosinophils, then your diagnosis is almost certain, right? Okay, so this is a story of a patient from one of the published literature. So at the time of presentation, this is what we saw on the X-ray, right? It almost looks like ARDS. Do you agree? Bilateral fluffy alveolar infiltrates. Now the same patient, when he was treated later, the ARDS kind of X-ray picture is completely resolved, right? Okay. Now, how do we diagnose this patient? The diagnostic criteria are very simple. Now, you already have an idea. So, patient presenting with acute febrile illness with respiratory manifestation of less than 1 month duration. As I've already told you, most patients, they will present within 1 week of the onset of symptoms itself, because by that time, the respiratory failure progresses quite rapidly. They have hypoxemic or type 1 respiratory failure. There will be diffuse pulmonary infiltrates on the chest X-ray, resembling very much like ARDS. And when BAL is done, eosinophil count is more than 25%. Obviously, we have to rule out other causes for the eosinophilia. So parasitic, fungal or other infections should be ruled out. And also the drugs known to cause the pulmonary eosinophilia like NSAIDs and antibiotics should be ruled out. Now, last thing is, we have to remember that acute eosinophilic pneumonia has excellent response to steroids, and it is one of the defining feature of it. So if there is a quick clinical response to corticosteroids, like I have to tell you that most of these patients improve within 48 hours of initiation of steroids. Like the patient presented with ARDS like picture, we had to put him on ventilator because of such a severe hypoxemia and dyspnea. And upon starting the appropriate doses of steroids, right, within 1 or 2 days, he will reach a situation where you can start thinking of weaning. In a given case of ARDS, that's not going to be a practical goal, right? Okay. And then the last feature is also important. It is something that helps us to differentiate it from the chronic eosinophilic pneumonia and other conditions where there is pulmonary eosinophilia. That is a failure to relapse. So it is like a monophasic illness. Most cases, it is not going to relapse. Even if the person continues to smoke, the relapse rate is extremely, extremely low. Okay. So this is the diagnostic criteria. Now, how do we manage these patients? These patients are managed mainly with steroids. By now, you have a clarity that they have excellent response to steroids, right? So, corticosteroids are the mainstay of treatment. The usual dose is prednisolone, 1 milligram per kg per day, generally given for 1 week, and then after this 1 week, tapered over next 1 week. Tapered over 1 week. Most patients will respond to this dose. Okay, those patients who had much more severe clinical presentation and they were ventilator dependent, such patients, higher dose of methylprednisolone can be used. But most patients, we use prednisolone 1 milligram per kg per day, or its equivalent dose of other steroids. At the end of 1 week, you will be able to start tapering, and you can taper off quickly over next 1 week. So 2 weeks is max you will be treating these patients with steroids. Okay. Most of these patients do not require any additional immunosuppressant therapy because they have excellent response to steroids. And as I've already told you, improvement is expected within 48 hours. Within 48 hours. I don't mean complete resolution, but significant clinical improvement in the form of reduction in the inflammatory markers like CRP and even the IgE levels, improvement on the clinical parameters, reduction in the eosinophil count, and over time, you will also start noticing radiological improvement. Okay, so this is a summary of our acute eosinophilic pneumonia. Now, talking about the chronic eosinophilic pneumonia. Now, these are the patients who generally present with subacute to chronic respiratory illness characterized by like over weeks to months of symptoms. Most patients will have 4 to 5 months of symptoms before we even start thinking of chronic eosinophilic pneumonia. And the symptoms will be in the form of dyspnea, cough, and night sweats and generalized weakness and sometimes systemic manifestations. When you look at the profile of these patients, right, the gender wise, here females are more commonly affected than males. So when I was talking about acute eosinophilic pneumonia, I said a typical patient is a male who just started smoking. Here it is female who are more commonly affected than males, and the age wise it is like 30 to 55 years of age. So a patient of chronic eosinophilic pneumonia is also young, but not as young as a patient of acute eosinophilic pneumonia. 20 to 40 is what we were talking about when we spoke about acute eosinophilic pneumonia. And in terms of the risk factors, right, there we learned that it is someone who is non-asthmatic and taken to smoking recently. Here it is an asthmatic. So most of these patients either get diagnosed as asthma during this presentation with chronic eosinophilic pneumonia, or they are known case of asthma. So a typical patient of chronic eosinophilic pneumonia is an asthmatic in the age range of 30 to 55 year old, mostly female, who presents with subacute to chronic respiratory complaints in the form of cough, dyspnea, night sweats, and low-grade fever. Right? Now, for such a presentation, in India, we would also have thought of tuberculosis as a differential diagnosis. Okay. Now, the presentation is not as dramatic as acute eosinophilic pneumonia. Acute eosinophilic pneumonia almost presented like ARDS. Majority of these patients landed upon the ventilator. Steroid is the one that salvaged them. Here, these patients do not develop severe respiratory failure. Mild dyspnea not associated with significant hypoxemia is the usual presentation. Okay. So when I talk about clinical features, these patients will have cough, dyspnea, which is usually mild. They have fever, which is usually low grade, and they have night sweats. Okay. And now because this condition is running over several weeks to months, there can also be weight loss. So that is why clinical features make us think of tuberculosis as one of the differential diagnoses, though once we do the imaging and other studies, things become clear. Okay. Now when we look at these patients' CBC during investigation, we will notice that more than 90% of these patients have peripheral eosinophilia. More than 90% patients have eosinophil count which is more than 500. So these have significant eosinophilia at the time of presentation itself. So when we were talking about acute eosinophilic pneumonia, I told you that at presentation, majority of them do not have peripheral eosinophilia. In case of chronic, they have at the time of presentation itself. Okay. When we do the chest X-ray or HRCT, we will see bilateral consolidations and infiltrations. And we have to remember when I say consolidations, right? These consolidations are pleura-based. Pleura-based, or in other words, they are peripherally located. They are peripherally located. Okay. Now, in terms of the X-ray, it's going to look something like this. So if this is your lung fields, your opacities will be peripherally located. And the opacities are more denser on the upper zones and mid zones. Okay. So you will have opacities which are distributed like this towards the pleura or periphery. So this X-ray appearance sometimes makes it look like the negative image of a patient's X-ray with the pulmonary edema. Right? In case of pulmonary edema, where are the infiltrates located? In case of pulmonary edema, infiltrates are fanning out from hilar, right? What we call as bad swing appearance. So it is exactly kind of opposite of that, peripherally located infiltrates. So the X-ray looks like the negative of the patient with pulmonary edema. So that is why it gives rise to a radiological sign which is known as photographic negative pulmonary edema. Photographic negative pulmonary edema. And this is a very important radiological sign. You can get an image-based question, and there can also be an MCQ asking you, where do you get photographic negative pulmonary edema? We get that in patients with chronic eosinophilic pneumonia. This image finding is seen in less than 25% of chronic eosinophilic pneumonia patients, but it is highly suggestive, or I can say it is pathognomonic of chronic eosinophilic pneumonia. But in most other patients, the opacities may be less marked or may not be so well established bilaterally that it would look like a negative of pulmonary edema. But still we should be aware that these opacities are pleura-based or peripherally located. Okay. Now such a patient, when he is subjected to bronchoalveolar lavage study, we will see that more than 60% eosinophils will be there. More than 60% eosinophils will be there. So when we were talking about acute eosinophilic pneumonia, 25% was the cutoff to call. Here we will be seeing more than 60% of the cells as eosinophils. Okay. So with that, we will have a clear idea that we are dealing with a case of chronic eosinophilic pneumonia. What clinically we thought of as possible tuberculosis turns out to be chronic eosinophilic pneumonia by looking at the X-ray and the ball fluid. Okay. And peripheral eosinophilia might have given us a little bit of clue, but we have to remember that tuberculosis itself can cause peripheral eosinophilia. Okay, so this is an X-ray image where you can see that there are opacities which are pleura-based and they are peripherally located. And as I have told you, they are more common or denser on the upper and mid zones. Okay, so this would be the distribution of opacities in case of pulmonary edema, bad swing appearance. It is exactly opposite of that here. That's why it is called as photographic negative pulmonary edema. Okay, now how do we diagnose these patients? Obviously, clinical suspicion. So we have to think of chronic eosinophilic pneumonia in a non-smoker, asthmatic female, asthmatic female presenting with subacute to chronic cough, dyspnea and fever, cough, dyspnea and fever. And on investigation, you have photographic negative pulmonary edema features plus ball fluid, which is showing more than 60% eosinophils. And also you will have peripheral blood eosinophil counts higher, right? So that's how we come to the diagnosis of chronic eosinophilic pneumonia. Now, how do we treat these patients? These patients are also treated with steroids, and luckily, even chronic eosinophilic pneumonia patients have very good response to steroids. The only problem is that unlike acute eosinophilic pneumonia, patients with CEP generally have a tendency for relapse. It's not a mono event. Okay. So corticosteroids are the mainstay of treatment. Generally, we use prednisolone or prednisone, 1 milligrams per kg per day. We give it for 1 to 2 weeks and then it is tapered off. 1 to 2 weeks and then it is tapered off. Here also improvement is expected within 48 hours. Within 48 hours of initiation of the steroids, we start seeing the improvement. But we have to remember that more than 50% patients show relapse. So the relapse might occur when you're trying to taper off the antibiotics, or sometimes several weeks to months after you have totally tapered off the steroids. Okay, and if relapse happens, such patients might require immunosuppressants as steroid sparing agents. Okay. Now, another good thing about the chronic eosinophilic pneumonia is though relapse occurs, they remain steroid responsive throughout. So every relapse is steroid responsive. So if I'm using immunosuppressants, I'm mainly using it as a steroid sparing agent. Okay, that is one option. Like you can treat this acute event with the parenteral or systemic oral steroids, and once patient recovers, if he's showing another relapse, again the relapse will be mostly treated with these steroids. But for prevention of relapse, either you can use low dose oral corticosteroids, or instead of that you can use immunosuppressants as steroid sparing agents. Our most commonly practiced approach is giving inhaled corticosteroids. Okay, for most patients this would suffice. Inhaled corticosteroids would suffice, but for those patients where they are on relapses despite being on inhaled corticosteroids, you can think of immunosuppression or low dose steroids. Okay, so this is about our chronic eosinophilic pneumonia. Now, there is one table. Let us do this exercise trying to compare acute eosinophilic pneumonia and chronic eosinophilic pneumonia. If we're able to do this, we can handle most of the MCQs coming from this. Okay, so age-wise, what is the age for acute eosinophilic pneumonia? 20 to 40 years, so relatively young individuals. 30 to 55 years with a median of 45 years for chronic eosinophilic pneumonia. Gender-wise, in case of acute eosinophilic pneumonia, males are more commonly affected than female, and it goes without saying, right? It is the males who smoke more. Females are more affected than males in case of chronic eosinophilic pneumonia. Smoking is an important cause for acute eosinophilic pneumonia. Smoking has no role in chronic eosinophilic pneumonia. A patient of acute eosinophilic pneumonia is generally non-asthmatic, and chronic eosinophilic pneumonia is typically asthmatic. Peripheral eosinophilia, in case of acute eosinophilic pneumonia, it is not known to occur at the time of presentation, at least. In case of chronic eosinophilic pneumonia, it's a common feature. Ball eosinophils, more than 25% for acute eosinophilic pneumonia, more than 60% for chronic eosinophilic pneumonia. Now, respiratory failure, type 1 respiratory failure occurs in patients with acute eosinophilic pneumonia because it's ARDS-like presentation. It's very common. It is rare in case of chronic eosinophilic pneumonia. Hypoxia is rare. Dyspnea occurs, but they're generally able to compensate and maintain their saturation levels. On imaging, in case of acute eosinophilic pneumonia, we will see ARDS-like imaging features. And in case of chronic eosinophilic pneumonia, we learned about something called as photographic negative pulmonary edema, or you can simply say that here ARDS-like and here it is reverse of ARDS-like. Okay. Relapse is rare, very, very rare in case of acute eosinophilic pneumonia. More than 50% patients relapse in case of chronic eosinophilic pneumonia, right? So I think we have addressed all the MCQs that can be asked from these two. Even if they ask you a clinical oriented question, you should be able to answer now. Okay. Now, after this, the last eosinophilic lung disorder I'm addressing in this video module is hypereosinophilic syndrome. Only basic parameters because it's more of a hematology topic. Okay. Now, what is hypereosinophilic syndrome? It is a condition where patients have persistent eosinophilia, which is defined as the peripheral eosinophil count of more than 1500 per cubic millimeter. Okay. And there is organ dysfunction, end organ damage or dysfunction. So when both of these occur, there is persistent peripheral eosinophilia with a eosinophil count of more than or equal to 1500, and there is organ dysfunction. Such conditions are called as hypereosinophilic syndrome, right? And more than 50% of these patients have lung involvement. Lung involvement, and lung involvement will be in the form of bilateral infiltrates in most of these cases. Now, in terms of cause for hypereosinophilic syndrome, there is a classification that you will learn in hematology. There is lymphocytic, myeloproliferative, unclassified, and idiopathic. Okay, and there are also more detailed classifications. If the hematology colleague is considering it important, please go through that. Here, I want you to only understand few important points. The point is that hypereosinophilic syndrome might resemble like any of the pulmonary infiltrates with eosinophilia kind of clinical picture. But unfortunately, these syndromes have poor response to steroids. Poor response to steroids. So less than 50% of patients respond to steroids. So majority of them would require immunosuppression in the form of methotrexate, cyclosporine. And because now we have started understanding the role of certain genetic mutations and all, we have the role of tyrosine kinase inhibitors like imatinib. At least in myeloproliferative forms, we can use imatinib mesylate as the drug, right? So the take-home message is very simple. From the respiratory side, they can ask you what percentage of patients have lung involvement. It's more than 50% of the patients. They can ask you what is the eosinophil count that is required for diagnosing the case as hypereosinophilic syndrome, that is 1.5K plus, and how is it different from the other known diseases like acute eosinophilic pneumonia, chronic eosinophilic pneumonia and all. In terms of responsiveness to steroid, it shows very poor response. Less than 50% patients respond to steroid. Majority of the patients would require immunosuppressants or imatinib. So with that, I'm signing off, guys. I'll see you in the next video module discussing another important topic. Till then, have a good time.